therapist may say almost nothing, may be involved in no activity in terms of movement, may not even interpret material for a long time, may make no comments unless it's absolutely necessary, simply becomes the participating observer. Just as we have in normal ego function, an observing ego and a participating ego, you can think of the kind of sensory hypnoanalysis that I've been trying to describe as the modular equivalent of a participating and observing ego. At first, the patient is an observing ego and is observing what's being intervened. Then becomes the participating ego, and the therapist becomes the observer. Now let me, in a more systematic way, just describe some of this. New ideas in science are generally induced by new discoveries. At the present time, it seems that the most potent factor in promoting new discoveries has been the introduction not of brand new ideas, because I don't think in the history of psychotherapy we really have uncovered in recent years any great new ideas. We have uncovered new techniques, new strategies, new tactics. But if you read, and many of you have, the older literature of psychotherapy, there are no great new discoveries really since Freud's awareness and recognition of the unconscious, but only new techniques, modifications of techniques. But those techniques constitute discoveries. Scientists have been at it so long that most natural phenomena and all events, particularly those of the inanimate world, have been pretty well scrutinized. And therefore we run into the problem that most young therapists have already a well-stocked pantry full of ideas and facts, and they're not really ready for some new ones. Hypnosis offers a possibility of being much more inventive and much more creative, and that based on individual means of intervening, one can do things on one's own. One can do things differently as the case indicates.
Ridurla a migliori rapporti con noi.
Are there any questions in what Professors Marcus and have said, but rather a reaffirmation of the importance of being able to recreate meaningful emotional experiences. And yes, in regard to the one question, many therapists use what's known as the house tree person test, in which patients draw houses and trees and persons and project onto those drawings many of the unconscious feelings and ideas that they have. And as such, they serve as meaningful guides towards the evaluation of the level at which they're functioning. Of course, we could get lost very rapidly in the whole issue of regression and regressiveness. And age regression or prenatal regressions are of interest. They become somewhat esoteric in a way, because with every kind of regression experience, we always have a component of fantasy that comes in. And I think it is the wise therapist who will carefully differentiate between the fantasy evocation and the meaningful traumatic recollections. And there is much masking and much screening of material. But the process within which this takes place is what is most important. And the thing that I would like to really focus on, and I agree with all that has been said, and I don't view them as questions but as important contributions. But of course there is one problem, I think, in terms of therapy, which Professor Marcus, to my right, has emphasized, but he hasn't emphasized it as strongly as he should. Regardless of strategy or technique, there is an individual characteristic of the therapist himself or herself. And in this case, we have a very powerful psychotherapist who is capable of drawing the patient into a very meaningful alliance. And you can feel the energy and the vitality. And that is something that one cannot usually devise by technique or strategy. That is something that is an inherent part of the character structure of the therapist, as wise and as experienced as Professor Marcus. But for the rest of us who do not have such characteristics, we have to rely upon strategies and techniques and instruments. And that's why we build libraries, you know. We can't remember everything that's ever been discovered or written down. So we build libraries and we put all that data in there so that when we need to know something, we go and get it. Other individuals retain everything and they can remember what happened in Messina 200 years ago, whereas I have trouble remembering what happened in Milano yesterday afternoon. But so much for that. But what I would like to really emphasize today simply is that we should not follow the beaten track in terms of hypnotherapy, and that we should be able to expect that if we want to create a better instrument, we ourselves are capable of doing that within the confines of the individual patient and the manner in which that patient reveals himself. So that in essence, there are two tracks that we have developed in terms of sensory hypnoanalysis. And I will very simply describe the two tracks. Although when you do anything simply, much is left to one's imagination, but I think you have good imaginations and experienced imaginations, so I think you'll fill in the details. One is having the patient focus on some aspect of their sensation, on some aspect of their bodily sensation, of their visceral sensation, some aspect of their awareness. And I'm using this in a fairly broad sense so that you have to be able, and I'll describe it with a few cases, to focus on what it is that they are presenting and what it is they want to share with you and what it is they want your help with in clarifying and in bringing into more consciousness, even though part of them is saying, I want this and I don't want this. And that double bind that they're creating is part of their neuroses. There will always be a part of the patient who says, help me, this is where I need help, and I expect a lot from you. And another part is saying, I'm not going to let you do it. No matter how hard you try, I'm going to stand in your way. It's as if there was a little demon inside that says no, and the other one says yes. And it is our job to intervene and to go through that very narrow passageway so that we can deal with both aspects, with both sides, with both ego components of the patient. Now, as I say, there are two tracks. One, we focus on these bodily awarenesses, these bodily sensations, and we ask the patient's help in the initial stages to tell us what it is that is dysfunctional about him or herself. Without their assistance in describing their dysfunction, we are at a loss to help them, because otherwise we're going to impose upon them what we think is their dysfunction, and what we as therapists think as the patient's dysfunction may not in reality do justice to the degree to which they are impaired. And therefore our diagnostic, our elucidating techniques, and some of the drawing devices which Professor Markuson made reference to are important when they're necessary. At other times, we can do this more easily and directly simply using ourselves. Now, the second track is really for patients who tomorrow I will go into much greater detail about, and that is alexithymic patients. Patients who lack the ability to describe their dysfunction, only to be, to use blunt terms, complainers. I don't feel well. I don't have any energy. I am depressed. I don't like my job. I get headaches. I have high blood pressure. I have all kinds of things. But when you ask them, well, what is it that bothers you? What are the feelings that you experience that are troublesome to you? I don't know. They don't find the words. They don't have them. We try. These patients, they cannot focus on meaningful bodily associations, bodily awarenesses, bodily sensations, the whole realm of the sensory order. These we use a process which Radzinski, I say it slowly for the translators, Bernard Radzinski of Montreal described as sensory hypnoplasty, which is a form of sensory hypnoanalysis. And Ben Radzinski and I worked together for many years and shared many identical concepts and ideas. He was very creative in using plasticine, and he worked with many alexithymic patients. Plasticine, as you know, is clay, modeling clay. And what he would do would be to take modeling clay and add a little bit of oil to it, Vaseline, to make it more malleable, soft. And then would have the patient, under hypnosis, use his hands to feel the clay, and not to necessarily make anything, but just in a very non-directive way, in the same non-directive way that we will tell a patient, feel yourself, feel your body, feel your arms, tell me how your legs feel, what's in your heart. If one gets a little more philosophical, one might say, what's in your soul, to more articulate and sophisticated patients. Again, the criteria is something we have to examine more closely. With hypnoplasty, the same device, just use your fingers and keep modeling, keep molding, keep shaping. Don't let those fingers stop, ever. And what happens is, you then say, and tell me everything you feel. Some of the associations which come out are very dramatic, and very often Dr. Roginski would add, with certain patients, certain components to the clay. For those who were anal in characteristics, he would add a brownish coloration which would look like feces. For those that had other aspects who were concerned with cleanliness, he would add a white component. In other words, he would match their characterological structure with coloration, so that this clay now had some lifelike association. It was not something that was dead and dormant. But in either case, the associations are the things that happen. Let me describe a brief verbatim transcript. And one of the advantages that we have in terms of some of the research I made reference to earlier this morning is that we have permission to record totally what goes on. This is an abstract of a session. This is a 42-year-old male, a professional person who is compulsive and obsessive, is very depressed, rigid, hypochondriacal. He's very stingy in his whole lifestyle, although he need not be so. He's hostile and dominating. He suffers from an irritable bowel syndrome and a number of other psychosomatic manifestations. Prior to the interview, which is reported here, taken from the segment, he had had several sessions in which stool-like associations, and in one case we did use plasticine with him, stool-like clay had shown for him marked revulsion, and he had hostility to it on each occasion. In other words, when he was given the clay and was told that it was and felt like a stool, he would get very angry and very upset. We used the same type of clay in order to break down his defenses. Now, under hypnosis, this is what the patient said. Do they have I can hear their translation. Well, let's stop. You belong to me. And he said this with deep feeling. He's referring to the clay. You belong to me. No one is going to take you away from me again. I love you. And then he put the clay in his mouth and he began to sniff it. I dream about you. I hold you close. You're my only belonging. Everything else has a catch to it. Everything else has an involvement. You have to pay for it. This is free of charge, and I can have it any time. Free. He says this with much emphasis, not as calmly as I say. With emphasis and feeling, great feeling. It is something to have for free and not to have to pay for it. That's what makes it so precious. Just to have something free and not to have to turn yourself inside out for it. You notice the language structure is interesting for a man with an irritable bowel syndrome. It's an exciting feeling to have something free. No one to supervise you or to ask you questions. A precious heritage, something of your own. You made it. It responds to you. It doesn't fight back. It doesn't make demands on you. I want to be free, and he shouted that. Love must be free. Love must not be attached with prohibitions and restrictions. It must be uninhibited, not interrupted. Don't interrupt me. He addresses himself here to the world, not to the therapist, because the therapist was saying nothing. It changes my pace, my time, my way. Every heart has a different beat. This can even be human flesh today. It could be divine. It's not dirty at all. It's a nice color, it's human. Nothing wrong with it. To touch, to smell, to bite, and he does all of these things. It's human divinity. If you can get there and touch it. They always spoil your love. They always spoil it. The world can't receive it. Your wife can't receive it. Even your doctor can't receive it. Even I can't. But it can. It's born free and can be loved. I raise you from the bowl. I raise you from the dead like Lazarus was raised from the dead. You are out of the toilet bowl, and you become my loved object and close to me. It is freedom as I have never known it. At this point there's a tremendous amount of sighing, continuous deep sighing. He goes on, you sigh because you find the depth in it and in me. You find the love that knows no bounds. It's enormous, it fills me. Then I have the strength, the veins to fill up, and I begin to be a father, a husband, a lover. I find my depth and I can use it. The sap goes to my very roots. This will teach me how to love. This opens the doors, many doors. So many doors were closed to me before. So many avenues were closed, countless ones. Love is powerful, it's vibrant, it's exciting. It twists me into contortions, almost too strong for me. I was dead from the feet up and from the hair down. I've been dead. Now I can walk, think, love, and fuck. I was dead before. I'm being born again, alive again. He now puts the clay all over his face. And all that it means to be alive again, like a spirit coming out of you, like a release from bondage. So much was there. I have been a slave. I have been a slave. Now the patient's removed from the hypnosis, and in a waking state, he goes on, I never felt such a spirit. It was almost too great for me. It shook my frame to its roots. Of course, when you release something so powerful, you get a reaction. Something you harbored all your life. It's a release from prison, from bondage. It's like restoring the inner being, giving life back to me again. This is giving my soul back to me. It surpasses words at times. It defies description. So great. I can't really describe it. It's a life force. That's what it is. Libido. It's intoxicating. A wonderful feeling of elan. Thank God for you. I can only say that it was supreme. Like nothing I've never had before. Supreme. Just marvelous. I still have the thrill inside of me. I quiver with excitement. It's greater than any sexual experience I've ever had, or any pill, or any experience I've ever had in my life. It's greater than any great praise I ever had, or any great accomplishment, because it comes from within. It's just marvelous. You once released part of that when you brought me back to the age of 4 in hypnotherapy previously. But this was my real self, not related to an incident. He's referring to the reliving simply of an incident. It's so great that I'm almost overwhelmed. I'm really dizzy. I'm almost afraid of it. You can't live in darkness all your life and then suddenly get the light of day. You wonder if you'll almost burst. It's like an explosion inside, tremendous force. Following this session, the patient showed basic general improvement in much of his behavior, in many of his attitudes, and he continued in therapy for some time and made great progress. But you see here, you get the patient's verbal, linguistic expression of what Professor Marcusson was personally projecting and describing as the force, the life force, the energy. But that life force and that energy has to become externalized. And the only way human beings can externalize it is through language. It is not enough to simply abreact an age regression and to live through a trauma. Yes, for desensitization, patients with post-traumatic stress disorders who have flashbacks and are hooked onto traumatic experiences, the kind of desensitization and abreaction that Sargent originally described and that we've used with veterans of the Vietnam War and from other war experiences is useful. as a ventilating device. But I think you see here, in the language of the patient, not the language of the therapist, not the ideas of the therapist, not the concepts of the therapist, but in the language of the patient, the experience, the feelings, the affects, the force, and the breaking through of things that he was terrified of before. A hypochondriacal man suffering from irritable bowel for years, depressed most of the time, speaking in limited monosyllabic terms, and being very hostile and very uncooperative. Now, and this is not the sum of the whole therapy, obviously, but with the use of this technique, he suddenly realized, and this is what's important, he suddenly realized that he could break through, not that the therapist could break through. And this reaffirms a concept made a number of years ago by the analyst, well known, I suspect, both in Europe and the United States, although he's an American, Abraham Gardner. Abraham Gardner today is about 93 or 94 years old. He was first analyzed by Freud. But Gardner has frequently expressed the idea that no patient is freed of neuroses until that patient can experience self-mastery. And that too often therapies deny patients self-mastery. And many therapies, not necessarily hypnotherapy, but many therapies emphasize therapist mastery, therapist ability to cure the patient. I think all therapists, good doctors, have the great desire to cure patients. But in doing so, they get caught up with being the more masterful member of that alliance. And I think in psychotherapy, more so than in any of the other healing disciplines, we have to give the patient the sense of self-mastery, the patient the sense of self-healing. He must have that power. And it is this self-directed sensory process that permits self-mastery to emerge. Not always in one session, and there were many sessions before this, obviously. But from this point on, there was a breakthrough. And, for example, some of the language he used here, he never would use outside of hypnosis. He was too constricted. He was too contorted, too convoluted. But in giving him this regressive sensory experience, he was now able to make this great lurch, this great jump, as he himself described it, in better words. And as you can see, it would be very hard for any therapist to describe in language the real experience that this man went through in terms of the kind of language he organized. And that language is a real index of what he was experiencing. One has to, for its full concept, hear it, because it has intonation, it has affect, it has emphasis, it has theater. And, you know, it was Sargent, the British psychiatrist who worked during World War I with abreacted experiences, who said that abreaction is really theater. It's theater with all the drama of theater. And that if we do not produce that in neuroses, we will never cure or free a patient. And to some extent, this kind of breakthrough is necessary. I'm not in any way implying that there are not other ways of getting these breakthroughs. And I wouldn't say that there aren't other therapies that can do it. Of course they can. It seems to me, from our experience, this is a much more direct and a simpler method. It is not very complicated. It is so simple that someone sometimes says it's almost on automatic pilot. Once you have focused the attention and the sensation and the involvement, what comes out almost ceases to come out. And it has different forms. They're not alike. For example, if I can indulge you a little more. A 27-year-old married woman was seen at the recommendation of her physician and priest. She was severely depressed, increasingly dependent on alcohol, and involved in a great deal of promiscuous sexual behavior. During 2 initial consultations, she found it almost physically impossible to talk. If it had been a classical analytic situation, we would have had a 50-minute hour of silence. She said nothing. She simply presented herself. and said, I'm here because my doctor and my priest said I have to come. I have trouble. That was all she would say. That's all she could say. During 2 consultations, she was encouraged to say a little bit, but very much lacking. She couldn't even verbalize answers to direct questions. Sometimes, like I can remember, she was asked, when you have an extramarital sexual experience, what is it that makes you feel you need to have it? She didn't indicate she didn't wish to answer. She just said, I don't know. And that was the end of the conversation. The 3rd session involved hypnosis, in which all of the attention focus in hypnosis was on sensory imagery. She was told that she would visualize her body, and that she would not only visualize it, but she would be able to feel it, and that she would be able, and again the language is firm and direct, it doesn't matter how accurate it is, that she would be able to visualize it, she would be able to sense it, she would be able to smell it, she could touch it if she wanted, she would be in contact with almost every cell in her body if she wished to. Always the permissive aspect, but at the same time a firmness, so that if one wants to use a metaphor, it is a firm but gentle approach to saying, this is what you must do, but you have the right to negate it if you want to. She was told that she would be able to sense everything that was going on within her body, not her mind, just her body. No verbalization took place during 45 minutes of hypnosis, not a word. In one of the modifications of this therapeutic procedure, we have an adjacent room to our treatment rooms, in which patients, after they're dehypnotized, can go into the room, and there is writing material, there is paper for drawing if they wish to, there's a tape recorder for talking into it. In other words, they can report in their own privacy anything that they now are aware of that they have not stated or described during the immediately preceding session. She went into this room, this soundless, uncommunicative, silent, depressed, withdrawn, detached, really quite alienated 27-year-old woman. And this is what she wrote. Actually, she didn't write it, I'm sorry. This is what she dictated onto the tape recorder. She really didn't have the energy to write. That's why she probably did not use pen and paper, but simply pushed the tape recorder. And this is what she said. A demon dwells within me, casting shadows upon my days, destroying any hope to be, relentlessly gnawing its prey. Day and night it torments, tortures, like a cancer, rotting to the bone. It will not leave me alone, not a minute, not a second. Seeping through all my veins, it paralyzes, terrorizes, to unfathomable depths. A veritable hell lies buried in this putrid piece of humanity, brutally destroying everything it nears, spreading vengeance, hate, hurt, haunting all it reaches. I could tear at this flesh that houses this monster called me, so ugly and hateful, and objects everything that it is, not worth a damn to anyone, to anything. It should be mutilated, it should be smashed to pieces, it should be thrown to hungry wolves before it permeates to greater lengths, before its vileness taints everything. Frightening feelings are these, compelling, lurking all the time, very close at hand, a pitiable state to be in, to loathe so much as to reach this degree and intensity of self-hate, to want to inflict such pain and horror because there seems no other answer, no place to put yourself, no joy to feel, no satisfactions obtained, nothing to hope for, nothing to live for, constant frustration, turmoil, growing by leaps and bounds, the omega of futility and fruitlessness. After 4 more sessions of this kind of sensory focus, she went into the room, and this time she used a pen and paper, and she wrote a poem. Warmth pervades the atmosphere. Someone to talk with beckons as you near. The eyes you watch, serene and fine, you know will treat you, oh so kind. The voice you hear, sincere and true, you know will open your heart anew. No need to pretend, no need to amend, for now you do not have to flee. The hurt you have felt, the torment once hidden, the tears, the fears, repressed for years, flow steadily through, until you can find the self lost to you, who you never knew. Now, the above material reflects the verbal and imagery activity which stemmed from the interlocking with sensory functions. This woman went on to make considerable use of continued therapy for only about 3 more months. And follow-up studies revealed that she was functioning again very well, resumed her family life, went back to school, and became a registered nurse eventually. And the last we heard, she was a psychiatric nurse working with schizophrenic patients. These are some of the fragments of the kind of material. The thing which is striking about all of the material, as one reviews thousands of hours from different therapists of the procedure. And I emphasize different therapists for the reason that if one therapist can produce one kind of material and one kind of responsiveness, that's fine, but that indicates an artist. And psychotherapy is an art rather than a science, at least at the present time. And there are some therapists who are better artists than others. But what we need for the base level of operation are people who are not great artists, but who are good therapists and who can use solid strategies and techniques to help a wide range of patients consistently and steadily. There will always be geniuses, there will always be great artists, and many of them are not trained in the art of psychotherapy, but they have a great knack for helping other people. They may be priests, they may be in all callings of life, but those are the exceptions, and that's not what is our concern. We get consistently this level of linguistic flow and linguistic structure and the externalization of internalized feelings that have been inaccessible up to this time. And as you can see, there is a level of integration that in itself reveals an emerging sense of self-mastery and self-integration. In other words, from a quiet, withdrawn, alienated self, you're suddenly getting an integrated self who can see the negative parts with the positive anticipation and expectation of recovery and of gain through her efforts, through her own efforts, who begins now not to attack herself, but to analyze herself. And the analysis is hers. It's not the therapist's interpretation. As you notice in this rendition in both cases, there is no interpretation presented. There is no therapeutic interpretation. This is simply the patient's presentation of what they are experiencing. And they're experiencing it at a very complex level. And the complexity is to be derived by an understanding not only of the language, and the language is most meaningful, but as I say, the affects, the manner in which that language is conveyed, both in its structure, in its syntax, and in its meaningfulness. So that it is for this reason that we have been very encouraged by the consistency of this kind of approach in really freeing patients of those resistances, of those repressions that make it virtually impossible to break through in more conventional psychotherapy and even in more conventional, and there is conventional hypnotherapy. There would be little way of breaking through some of this with positive suggestions. But by unlocking her unconscious, by triggering her unconscious, we gave her and the gentleman I read before the ability to do this on their own. And even though they may not always make reference to doing it on their own, they know they're doing it on their own. And they have a sense of power that begins to emerge from this, a sense of not being helpless. And probably anybody who has been a therapist knows that patients trapped in the dilemma of their neuroses suffer from many different issues in terms of feelings, but one is paramount, and that is the sense of helplessness, the sense of not knowing how to deal with these feelings, of not knowing how to get out of them, and hoping that somebody will do it for them, which is very difficult to do. All right, if there are any questions. Interpretation is a very delicate issue, as you have just described. I think very often patients do not interpret their material. They describe their feelings and their associations to it. I think if there is some aspect of that association or that description which seems to be counterproductive or at variance with aspects of their managing their own feelings, then I think the therapist should attempt to clarify the meaningfulness of that dream. If, on the other hand, there seems to be a thoughtful and productive association, a thoughtful clarification of what feelings are present, and if there are feelings that come from the dream, then I think they are best left to the patient's own management. As Sullivan has said, really sometimes the greatest damage we do to patients is by too rapid interpretation, and by interpretation which comes from the so-called sophisticated insights of the therapist rather than the feelings of the patient. So that interpretations should be given cautiously, they should be timed appropriately, and very often I have found it useful to withhold interpretation of material until some later point in the patient's own development of self-understanding, until their insight has evolved into a more mature and more reality-oriented perspective. At that point, to go back to some earlier material and remember the dream you had 2 weeks ago, or remember the dream you had a month ago. Let's take another look at that. And then with some assistance and some help, I think very often the interpretation should be a joint process, rather than, in the more traditional sense, an authoritative interpretation. This is what it means. You know, it's like somebody taking a sample of urine to the laboratory, and then somebody reading the report and saying, well, look, this is what they found in the laboratory. This is the analysis. Well, I think that kind of interpretation can be very harmful, and I think more and more we're leaning away from premature interpretations. I would, however, agree with something you implied, although you didn't state it, or at least I didn't understand it as being stated that clearly, but it was clearly implied. I would avoid negative, catastrophic, traumatic interpretations, even though they may be implicit in the patient's productions. Some of the productions I read today were generally freeing productions and very positive ones. There are times when one is caught in the midstream of this and what comes out is very conflicting and very traumatic and upsetting. I think at that point, rather than interpretation, one gives some clarification which holds out hope for further understanding and further insight into this process without implying that one is stuck. I think the greatest danger lies in leaving patients with the feeling that they are stuck with this. I think so long as they have the sense that they are sharing this with you, that they are in an alliance with you on this, and that even if it is not as yet fully resolved and understood, that it is going to be, then that in itself is sufficient interpretation. But again, I kind of paraphrase Sullivan, and we'll go a little more into that. Many problems that patients have are resolved rather than interpreted. And I think our ultimate goal in the treatment of neuroses particularly is the resolution of conflict, not necessarily the insightful sophistication of the understanding of that conflict. I think we want it resolved. We don't really care that they understand it the way we understand it or the way we think we understand it, so long as it is resolved. And I think working through that process of resolution is what hypnosis is very effective at, because the support that comes from the hypnosis and from that relationship and that hypnotic transference lends itself to giving the patient the strength, the confidence, and the expectation of recovery on their own, and the fact that resolution is at hand, and that they're not doing it totally alone, but they have support, but they are doing it through their efforts, and their efforts take on meaning and value for them. I don't know if that answers the question or confuses somebody's words. I think there are valid points that have been expressed on both sides. I think what we must bear in mind is that age regression is part of a total regression. It's part of a regression in terms of cognitive and perceptual mechanisms. And while there may be some very actualized memories that are imprinted, that are recalled in some instances, in others, like with patients with amnesia who begin to recall things for which they've been amnesic, they recall things at different points and then they have to add things in between to make them connect, and they make up those things. The difference between the amnesic patient and, in my opinion, the hypnotic patient is that instead of just making them up, they sometimes incorporate things that have been told to them at very early age levels, that have been read to them, that they have heard, that they have perceived. So that I think there is authenticity on both sides of this issue. Some age regressions may be very accurate and may actually revivify what has precisely taken place. Others have great emotional significance, even if the specific recall may be interlaced with material that is imported from other associations and identities. But I think, as you have expressed, we must be critical of what is going on so that we can maintain our objectivity and not be incorporated into it. But it is certainly, on both sides, there is a good deal of authenticity, and we need a balanced approach to what is involved. I might add that in terms of the centrality of regression, for those of you who are involved in doing age regression therapy or where it occurs spontaneously, I might suggest a little experiment which adds a little excitement but has no real danger. If you have access to a little doll which you can remove the head from, the dolls that children buy to play with, they're usually made out of rubber or plastic, but where you can remove the head. If it is somebody that you feel comfortable with, or it is a student perhaps you want to demonstrate, but not with a patient with a critical issue, when they're in a regress state, take the head off the doll and just show them the doll. You will then find out whether you have a real regression or whether you don't. What occurs then will very clearly reveal to you that you have a regress state or you do not have a regress state and you have a role-playing state. The two are totally different. But this is a very simple device, and you may be very surprised. I won't tell you what happens. But try it sometime. I would say in a situation, usually with a colleague or with a student or someone you can do it. There's nothing terrible that's going to happen, but it will be very revealing. Thank you. The technique is to use the plasticine, the clay, and to use the hands as a modeling device rather than to focus on the body when that is very difficult to do. And interesting you bring up the question because with plasticine, regression comes about very spontaneously. Perhaps in part because it is something that's connected with childhood anyway. Children use clay to model, to use their hands. But also the hands are such a basic and primitive part of our expression, both when we talk, when we feel. It is an area in which one can experience all kinds of sensations, whereas the rest of the body tends very often, as you know, to be defended against much better. And there is a kind of armoring of the body, which Wilhelm Reich described very well in his character analysis. But the hands are much freer. And we find that the use of the hands, as I'm sure you have too, is a very good route to other kinds of hypnotherapy, which are not necessarily dynamic or analytic in nature. Patients with migraine headaches frequently are helped tremendously by learning how to get their hands warm. And the moment the hands get warm, the headaches subside. The hands are a good access point, probably the most accessible point in regard to your question, but the clay is very good. One other aspect, for those of you who might like to try using the clay, sometimes plasticine is a little hard to work with in that you have to mix it with Vaseline and you have to make it squishy. But there is another product which children use that I prefer because it is easier, and I like to do things the easier way. It is called Play-Doh. It is very soft and very malleable, and you don't have to add anything to it. And it comes in all colors, and you can buy it in a toy store or in a hobby store. It comes in a little tube. It's called Play-Doh. Very, very effective and very simple to work with. It's much cleaner than the plasticine, which you have to clean up afterwards.